Hello, everyone. Welcome to our webinar, our inaugural webinar from the National Neonatal POCUS Collaborative. Hopefully you can see my intro slide. So I wanted to welcome our speaker today, Dr. Yasser Elsayed. We are gonna see this webinar is really a continuation of the ONTPD series on how to build a POCUS program. You can find that series in YouTube on the ONTPD channel. And this series is going to build upon that. Like I said, it's an educational series on slightly more advanced topics. And Dr. Elsayed has agreed to be our inaugural speaker. So we are so happy to have him here. In this webinar, the chat itself is disabled, but you can post your questions in the Q&A feature. All right, we'll monitor that during the throughout the webinar, and then we'll go back to those questions during the Q&A session. So as an introduction, our speaker, Dr. Yasser Elsayed, completed his pediatric residency in Egypt, a neonatology fellowship at the University of Manitoba, and an advanced neonatal echo and hemodynamics fellowship at Sick Kids Hospital in Toronto. Dr. Elsayed is an associate professor of pediatrics at the University of Manitoba, a staff neonatologist, a registered echocardiologist, and researcher at Manitoba's Children's Hospital Research Institute. He is the founder and director of Winnipeg's integrated hemodynamics and point-of-care ultrasound programs. His programs optimize the management of critically ill newborns by assessing end organ performance. In addition, Dr. Elsayed is co-chair of the International Point-of-Care Ultrasound Group, POCUS Neo. In the last 5 years, he has organized more than 100 workshops in Canada and worldwide. He is a prolific author, an accomplished teacher, and a passionate presenter of his programs and techniques. Welcome, Dr. Elsayed.
Yeah, thank you very much, Dr. Lawrence, for the introduction, and welcome everyone. So I will just go ahead and start my presentation. Can you see the first slide?
Yes, we can.
Okay, welcome again, everyone. It's my pleasure to be here today talking about point-of-care ultrasound and the crashing infant protocol. So I will try today to unveil some of the unknown pathologies related to different organs by relying on point-of-care ultrasound. I have nothing to disclose in this presentation. And I have 4 main objectives. And my objectives is to answer 4 main questions. And at the end of this presentation, the attendees will be able to answer, first, what is the aim of the crashing infant protocol? Sometimes we call it actually the crashing neonatal protocol. The second question to be answered, crashing infant protocol unveil the unknown in the lungs, heart, abdomen, and the brain. Third, what is the impact of applying crashing infant protocol on outcomes? And the last question to be answered, what is the technique of the crashing infant protocol? So let us go with the first question, the aim of the crashing infant protocol, and what is the story behind it? The main aim of this proposed crashing infant protocol, which is specifically designed for use in emergencies, leading to significant cardiovascular instability. So any condition that might be associated with hypoxia or hypoxemia, which might be related to cardiac or lung pathology or any other organ that might impact the oxygen delivery, then the ultrasound might delineate the underlying pathology or pathophysiology. Second, it can be used in infants who are either crashed, needing resuscitation, actually needing resuscitation right now, or crashing, likely to need resuscitation soon. And the crashing infant protocol proposes a stepwise systematic targeted assessment with simple basic ultrasound views integrated with the other markers. So the person doing the ultrasound should be the clinician at the bedside, aware about other clinical and biochemical markers, and integrate the ultrasound results to everything. So we are not talking about the technique that can be done by someone outside, from outside in ICU. The protocol was published last year as a consensus statement on applying point-of-care ultrasound in NICU. And as you can see here, we have 14 expert neonatologists in point-of-care ultrasound from 4 continents. And it is a great pleasure to have 3 of them available today among our panelists. So we have Dr. Shazia Bhombal, Dr. Maria Victoria Fraga, and Dr. Yogin Singh. So this protocol took some time for the group to get consensus on the technique and how to apply systematic stepwise assessment for 4 main organs. And I will go over the technique and the steps in this presentation. So how do we identify the crashing infant? So we have to define clearly the crashing infant. This protocol also was published and recognized by the American Academy of Pediatrics in the statement recently published on point-of-care ultrasound. There is 2 statements, the clinical report and technical report. And in the statement, there is a very clear definition about the infant who is crashing, including the indications of applying this protocol. For any infant unresponsive to resuscitation, you are applying resuscitation for a period of time and there's no response, and you need to understand why the infant is not responding to resuscitation as per NRP steps. Or infant with shock, and you need to understand, is it vasodilatory shock, is it cardiogenic shock, and is there any other organ might be affected with low perfusion, like gut injury with hypoperfused gut or not. Third, poor perfusion. You have unexplained poor perfusion, and you need to understand why. Do you need to give fluids, or do you need to start inotropes, or both? And then acute hypoxemia, any issue related to lung pathology. X-ray might not be enough in a lot of situations, and you need to apply a sensitive technique like lung ultrasound. And then unexplained acute anemia, if there is bleeding in any organ like subcapsular hemorrhage in the liver or spleen, or abdominal hemorrhage or brain hemorrhage, acute hemorrhage. So you don't have to wait until the radiologist perform ultrasound in 1 or 2 days. You can apply that right away and understand the underlying cause of hemorrhage. So we have a first conclusion of our presentation today. The crashing infant protocol is a multi-organ assessment by ultrasound in any infant or neonate with acute hypoxia or hypoxemia. And as you know, hypoxia or hypoxemia might be related to cardiac issue or lung parenchymal issue, or might be related to blood, like severe anemia causing severe hypoxia and decreased oxygen delivery. Now we are ready for the second and third questions. How does crashing infant protocol unveil the unknown in the lung, heart, abdomen, and the brain? And I will just show some case scenarios. And then the third question, what is the impact of applying this protocol on outcomes? The first step, or the first organ to be assessed, is applying lung ultrasound, point-of-care lung ultrasound, to rule out 3 main conditions, which might be related to lung consolidation or collapse. That might be due to severe RDS or lung hypoplasia, or compression of the lung by effusion, or compression of the lung by undiagnosed congenital phlegmatic hernia or cysts. So we need to understand the pathology in details, and in a lot of situations, as I will show you, X-ray might be misleading or insufficient. If the answer is yes, you need to apply the appropriate intervention like higher mean air pressure to give surfactant. If the answer is no, then check for pneumothorax, and you need to apply M-mode to rule out or to confirm pneumothorax. In this situation, if the answer is yes, you need to apply needle thoracocentesis in significant pneumothorax. If the answer is no, for lung compression or by effusion, then you have to apply or consider needle thoracocentesis. I have to mention that the crashing infant protocol is the diagnostic part and also intervention part. So if there is any pathology that you need to do intervention, that's included in the protocol. And the most common intervention, or the most significant to relieve significant compression of the heart, like in pericardial effusion, or significant compression of the lung in pleural effusion, that should be done immediately. So it is very important to consider intervention in a situation that is needed for emergency right away, and you have the expert person to do it. For assessment of the lung ultrasound, just reminding you, I think a lot of you already started learning lung ultrasound, which can be summarized in this slide. So we have 4 main patterns of lung ultrasound, and we have extra one, which might be the most severe form of lung parenchymal affection if there is any significant pneumonia or significant lung consolidation. So you'll see hepatization of the lung. So the lung looks like liver. That might be associated with severe pneumonia or severe lung consolidation. But if the lung is well aerated, you will see lines. So repetition of the pleural line as a just mirror image of the pleura. And in the situation, you have to check for sliding to rule out pneumothorax. And we are scoring that as a score of 0. And then if you see 3 or more P lines, longitudinal echogenic lines, reaching the bottom, this is signifying interstitial edema, which should be interpreted in the clinical context. If it is during postnatal transition, that could be related to TTN, or it could be related to interstitial edema secondary to, for example, PDA shunt. And we give a score of 1. If there's coalescence of these P lines and you cannot count them, which means you have almost out lung with alveolar edema, then we score as 2, and that's more severe form of lung parenchymal disease. And if you started to see air bronchogram with the interrupted pleura, then you have even more severe atelectasis with air bronchogram and give a score of 3. And again, the most severe form when you have consolidation. So you have more aeration when you go from the first pattern to the last pattern here was consolidation. And when you go with the less aeration, then the air will be replaced with more fluid. And the fluid can be just interstitial fluid or alveolar normal fluid, or can be transudation when you have pulmonary overcirculation or lung edema. So you have even more fluid, and that might lead to significant consolidation. When you see more fluid in the lung will be hypoechoic or dark or hepatized, almost the same like texture of the liver. When we apply the technique for lung ultrasound in emergency, we do 4 sweeps. 2 sweeps on the right side, anterior, lateral, and 2 sweeps on the left side, and that can be done in few seconds. Usually in less emergency situation, we check for the right upper, right lower, lateral, left upper, left lower, lateral. So 3 zones in each side, and we may assess also the subcostal area for pleural effusion in more details. A sweep that can be done over a short period of time in emergency situations. I will give this case scenario to just highlight the limitation of relying only on X-ray. We have this term infant 3 weeks old, admitted due to increased breathing and hypoxemia. Oxygen saturation was low, required oxygen. And then chest X-ray performed and interpreted by the radiologist as right side congenital rheumatic hernia, which were probably assumed to be missed at birth. We applied lung ultrasound immediately, and the ultrasound unveiled unknown in this case. So this is not congenital rheumatic hernia. It was multi-cysts. So pneumatoceles related to Staph aureus infection. And as you can see here, we have a limited, like small area of the A lines surrounded by B lines both sides. So there's one of the pneumatoceles with the multiple A lines in the middle, the same as you can see here. You'll not see the pneumatoceles as surrounded with the wall because the air limitation. You will see just area with the A lines surrounded by alveolar edema on both sides or B lines. Diaphragmatic hernia is very easy to be diagnosed by ultrasound. There's another case, infant born, undiagnosed antenatally as congenital hernia, just diagnosed postnatally in the delivery room with this ultrasound performed by one of our fellows. And as you can see here in this L2 area, there is an organ in the chest, which is spleen, and you have also tubes of the intestine surrounded by fluid. So typically you have abdominal contents in the left chest here. So this was left diaphragmatic hernia, undiagnosed antenatally and diagnosed immediately in the delivery room. We have another case scenario when the X-ray might be misleading the team. So 35 weeks admitted from ER at day 7 of life, was mild tachypnea, received 7 days of antibiotics with assumed pneumonia. The team assumed there is a pneumonia, right upper loop pneumonia, and that might explain the initial tachypnea, although the tachypnea was just due to mild viral infection. When we applied ultrasound, this area was just thymus gland, abnormal looking thymus gland, and there's no any pneumonia. Pneumonia should be like fluid bronchogram with hypoechoic background with consolidation or hepatization of the lung. In this case, the ultrasound unveiled the unknown, which was the thymus gland misdiagnosed as pneumonia. You can review our experience, local experience here in Manitoba of applying lung ultrasound as a first modality instead of X-ray. We're still using X-ray in some situations, but the lung ultrasound now is the first modality in our center. And we published 5 years of experience. And you can see over the 5 years, utilization of the lung ultrasound significantly increased. And since 2020, we started relying on our respiratory therapist instead of just relying on our physicians and fellows. So we have now 24/7 coverage of lung ultrasound, even the delivery room, at least at any given shift. We have 1 or 2 trained respiratory therapists are ready to do lung ultrasound at any time. So what are the cardiac causes of unresponsiveness to resuscitation? As per the published protocol, we have 4 main indications or underlying causes for unresponsiveness. We are talking about infant who's very sick or crashing. And again, we're talking about cardiac point of care ultrasound, not full hemodynamics assessment. So just a quick assessment of right chamber view, sternal long axis and short axis views over a short period of time. An infant who is really crashing, there is not enough time to do detailed echo. That can be done later by someone expert in hemodynamics. So we have poor contractility, cardiac tamponade, empty heart, you need to give fluids or reduce mini or pressure, or severe pulmonary hypertension with the right ventricle compressing the left ventricle. And these are the 4 examples. So the significant or poor contractility, and actually infant who is really during resuscitation, crashed or crashing, it is even beyond more contractility. It's cardioplegia. The heart here, this is for the infant who is still getting resuscitation by chest compression, fluids, and epinephrine. And you can see the heart is barely contracting. And you can call it cardioplegia. In this situation, you need to be aggressive in resuscitation, give boluses of epinephrine, and continue resuscitation until you get the heart rate up and perfusion improved. And then you have also the other example here with the significant pericardial effusion. And when you do sweep from posterior to anterior, you can realize easily that the most of the fluid collection at the back of the heart, as you can see here with the sweep. And this case was the preterm infant with the migration of the central line with the TPN escaped in the pericardial cavity, and the team tapped TPN from the pericardial sac. In the third example here, you see the right side is significantly dilated, compressing the left side in this severe hypertension with the infant with severe hypoxemia and required to start nitric oxide immediately. And you have the last or the case number 4 here, when you have significant underfilling of the heart gives you a false impression of hypertrophy. This is actually not hypertrophy. The heart recovered after giving boluses, and that might happen in a situation when you give too much in troops, or you give too much mean air pressure, compressing the heart, or you may have it also with the true hypertrophy with the infant of diabetic mother, but this is not the case. In this case here was due to high dose of inotropes and recovered after just discontinuation of inotropes and giving more fluids. What could be third space losses or just loss of fluids as a third space or outside the body, like higher in output, and then you need to replace the fluids because of the significant dehydration. Again, we have this 25 weeks, 5 days old, was stable on CPAP and became hypotensive and hypoxemic, required intubation, and the underlying cause cannot be delineated without applying point of care ultrasound, which immediately revealed significant pericardial effusion. And tapping was typically TPN from the pericardial sac. Now we'll move to another organ, which is abdomen. Abdominal point of care ultrasound is not very easy. You need to apply point of care ultrasound in normal cases. You need to understand how the normal intestine looks like in the ultrasound. You need to do a lot of cases with gut injury, including neck and other surgical cases to get the experience. So that might take some time, might take up to 1 year to get the experience on abdominal point of care ultrasound. Typically, we are evaluating gut ischemia and delineate the underlying cause of gut ischemia or presence of peritoneal fluid. The technique is a little bit complex. You have to apply longitudinal plane and transverse plane into the right lobe of the liver, and then the left lobe of the liver. You have to rule out any presence of portal venous gas or any abnormal cysts or collection or subcapsular hemorrhage or fluid collection. And then you have to apply the same 2 planes, longitudinal and the transverse, to right upper quadrant, right lower quadrant, left upper quadrant, left lower quadrant, and gut. And you need to do exactly the same in 2D and color Doppler. So this is the abdominal point of care ultrasound in detail to get all of the areas of the abdomen, including the liver. But in emergency, you may need to just apply longitudinal view into 4 main quadrants and also check the liver for any subcapsular collection or portal venous gas. You can get up to 12 different markers by applying abdominal point of care ultrasound. 9 of them by 2 dimension and 3 by color. You check for free air. Typically, free air, the standard is to check that by X-ray. But the air sometimes is insisted air, not really free, and that might be missed by X-ray, and you may check that or assess that by ultrasound. You may assess like insisted air, not really free in the abdomen, like if there's perforation and the perforation is concealed or insisted, then the ultrasound is more sensitive to detect that. Mural air or pneumatosis, portal venous gas, thickened bowel, the thickness should not exceed 0.26 centimeter and should not be lower than 0.11. Thinning of the bowel is a sign of severe ischemia. Thickening of the bowel is a sign of early ischemia. And then peristalsis, and then you may quantify peristalsis. Is it really impaired, sluggish peristalsis, or active peristalsis, or no peristalsis at all? And then intestinal signature, and I will show you that how to assess the multiple layers of the intestine with ultrasound, which is a sign of well-perfused gut. And when you see the abdominal, the intestinal wall as one block without layers, this could be a sign of ischemia. And then presence of complex fluids or peritoneal fluids, simple fluids, complex fluid, when you see septated fluids, which are also a sign of late gut injury. And then by color, apply 2 by 2 color box, and with low scale as a single digit scale, like maximum 8 or 9 color scale, because you need to detect the microcirculation, and you will see only speckles of color. 3 to 9 speckles within 2 by 2 box is normal. If you see Y-shaped color, that could be sign of abnormal hyperemia, or circles of color, or zebra color. And the significant ischemia, you will not see color at all. You will see just 2 by 2 box applied without any speckles or any color. This hyperemia, someone might say that it could be a sign of good perfusion. No, it is not good perfusion. It is just a stagnation of the blood in the big blood vessels, and the blood does not reach the terminal tissues. So you have just a stagnation of the blood, and that might be similar. You can consider it similar to vasodilatory physiology, when you have vasodilated big vessels and there is no good perfusion to the terminal tissues. Now we'll give you an example of pneumatosis intestinalis, which is quite easy to diagnose if you get the experience over time. So you have this lobe here with the pneumatosis, and there's no peristalsis. This normal lobe here with the peristalsis, and you can see some artifacts of air. And I know this artifact because I'm applying pressure with the probe, and the air can be moved away or disappear from the scene, which is a sign of just artifacts, not pneumatosis. Here, when I apply pressure, there is no any movement and staying within the wall. Portal venous gas is very easy to detect by ultrasound. Here you have massive portal venous gas, you have air moving all over the portal veins and the liver. That can be also detected by X-ray, but when you have mild, very mild collection of bubbles here in the portal veins, typically mild to moderate portal venous gas will not be seen by X-ray, will be only detected by ultrasound. We have some red flags of cases that require surgical interventions, including global thickening or thinning of the bowel. If you see all of the bowel walls thickened or thin, it is a red flag sign. Or absent gut signature, wall signature all over the entire bowel, or complex peritoneal fluids, or global absent perfusion by color Doppler. All of these are very bad red flags for potential surgical cases. And again, you have to integrate that to clinical and biochemical markers. So the surgical case should be very sick, clinically unstable, with worsening biochemical markers like worsening of leukopenia, thrombocytopenia, and sometimes hyponatremia, and also maybe discolored abdomen, infants very sick, requiring respiratory support and requiring vasopressors sometimes. Back to the gut signature. If you magnify any loop in the abdomen, you will see the loop layered into 5 layers, and you will see the inner layer here. Layer number 1 is the interface between the content of the intestine and the mucosa. And the mucosa number 2 here is hypoechoic or dark because it is well perfused, and the submucosa is echogenic. Musculosa is again hypoechoic or dark because it's well perfused. When we have well perfused layer, we'll be seeing dark or hypoechoic in ultrasound, and the outermost layer here is the serosa. If you're able to identify the 5 layers clearly, this is a sign of well-perfused gut. But if I'm unable to detect them, as you can see here, the thickened loop is 0.35, more than 0.26, which is the upper limit of normal, and you cannot identify the layers. This loop here is severely ischemic, and this case was one of the surgical cases. And here we have when we apply color Doppler, you have severe hyperemia with Y-shaped hyperemia, and the tissues inside very ischemic. So you have stagnation of the blood in the big vessels, and there is no blood reaching the terminal tissues. You have this example here. Both of them are surgical cases, require surgical interventions after ultrasound. In this case, 2x2 box, there is no any color Doppler all over the abdominal compartments. In this case, you don't have a perfusion. You have severely vasoconstricted blood vessels, and the gut does not get any enough oxygen delivery or blood supply. Typically, hyperemia due to a release of vasoactive intestinal peptide, which causes significant vasodilation. It is similar to the vasodilatory shock in the body. So you have also vasodilatory shock to the gut. And in severe vasoconstriction due to release of endothelin-1, which is very strong vasoconstrictor, in this case, that might be subjected to severe ischemia. This infant requires surgery and actually even passed away shortly after surgery due to global ischemia of the entire gut. We have here a preterm infant, another case scenario, 2 weeks old with bloody stools, abdominal cellulitis, and CRB of 60, leukopenia, and you can see massive portal venous gas. You can see peritoneal fluids. There is no peristalsis, nematosis intestinalis, and although there are some areas with good perfusion, some areas with poor perfusion, and another case of severe gut injury. Now we'll move to surgical cases beyond neck. We have this term infant with abdominal distension, and then the infant was initially in the well baby unit, was vomiting after initial feeds, and then the X-ray contrast showed the contrast stopped in the mid-gut. That was considered by surgeon as ileal atresia because the lactic acid was within normal level. But when you applied ultrasound, it was typical volvulus, and the lactic acid was normal because actually volvulus happened antenatally, and the lactic acid was corrected or already washed by the maternal circulation. So now we have the infant born almost stable, but there is significant volvulus, only diagnosed by ultrasound. So you can see the donut sign. So there are circles of bowel inside in the midgut, and with the color Doppler as wire pool sign, circles of color in the midgut, which is a typical sign pathognomonic for volvulus. This infant went for surgery, and about 10 centimeters removed from the midgut. Another case scenario, preterm infant, 23-weeker, post-menstrual age 40-weeker, abdominal distension, vomiting, lactic acidosis, very sick, and you have the X-ray with dilated loops, but you have a target sign here. You have loop invaginated in another loop, and the short axis is intussusception, which is very hard to be diagnosed without ultrasound. Again, you have almost mid bowel in the midgut here. You have invagination of the loops inside loops. This infant was confirmed as intussusception. In the statement of the American Academy of Pediatrics, we highlighted that the intestinal ultrasound is sensitive and specific compared to X-ray. So whenever you have expert person to do ultrasound, you have to go ahead and rely on ultrasound and maybe consider the interventions based on the integration ultrasound with other clinical markers. If you would like to read more about the intestinal ultrasound integrated to other clinical markers as a new approach to assess gut injury, you can also read this article. Regarding brain ultrasound, it can be very helpful if you apply it in an emergency situation. We have this interesting case, preterm 29-weeker, admitted with very sick in an ICU, unexplained low hemoglobin at birth. We applied almost at 1 hour of age the ultrasound, which revealed severe intracranial hemorrhage with midline shift. And when we investigated, we discovered that mother has history of physical abuse and the trauma, 2 weeks, and the hemorrhage here does not look like fresh hemorrhage, which explain the scenario. And this case was really a medical legal case. Is POCUS validated? When we validate any modality like ultrasound, when we compare ultrasound, for example, to X-ray, we have to have another modality to compare between both. For example, we compare ultrasound to X-ray in comparison to another standard like CT scan or MRI. But what's higher than gold standard is a ground truth. When you see the pathology by your eye, so my experience that I would like to share with you, I built my experience in abdominal ultrasound by looking at the pathology in the OR. So after each ultrasound for surgical cases, I looked at the pathology very clearly and compared that to the ultrasound. This will be published soon in a different article. So this is a ground truth. And we applied the same to the lung ultrasound. So in our animal lab, we validated lung ultrasound in this big model, and we compared lung ultrasound, to the histology and the VQ mismatch. So there's very kind of advanced hemodynamics and respiratory biology lab integrated with all of the monitors and special ultrasound machine dedicated for this animal lab. And we published this experience in lung ultrasound that predicts histological lung injury in the neonatal model of acute respiratory distress syndrome. So we induced lung injury in the piglet model and in different levels, moderate and severe, and also control, normal, and we compared the pathology to the lung ultrasound and also to the assessment of the physiology of the VQ mismatch. And the lung ultrasound was very predictive, very sensitive to detect the degree of lung injury. So we have now the conclusion number 2, the crashing infant protocol, Unveil unknown lung, heart, abdomen, and the brain pathology. Conclusion number 3, the point of care ultrasound can redirect management in more than 50% of the studies. So in the article that we published about lung ultrasound in Manitoba, in our experience, in 50% of the cases, the management was redirected, for example, from CPAP to ventilation, or ventilation to CPAP, or maybe to treat pneumonia, or to rule out any other diseases like congenital rheumatic hernia misdiagnosed by X-ray. In another 50%, the ultrasound confirmed the clinical assessment of the team. So it is redirecting the management 50% and confirm the clinical assessment and maintain the same management without a change as per the clinical assessment of the neonatal team. Now we have the last question. What is the technique of the crashing infant protocol? So to do the technique in details, again, you have to assess 4 organs. You have to apply 4 lung ultrasound sweeps, 2 on the right side and 2 on the left side, anterior and lateral, and quick assessment of the heart, apical foot chamber view, parasternal long axis, parasternal short axis, to rule out 4 main conditions: pericardial effusion, underfilling of the heart, severe pulmonary hypertension, or severe impaired contractility or cardioplegia. And then assess the liver for subcapsular hemorrhage, cysts, or portal venous gas. Assess the 4 abdominal quadrants. Assess the spleen for subcapsular hemorrhage. and then cranial ultrasound in 2 main sweeps, coronal sweep and sagittal sweep. You have 16 sweeps and images to cover, and you have to finish them in 10 minutes. And the expert person doing the crashing infant protocol, the 16 images can be completed in 10 minutes with significant understanding on what's going on related to the underlying cause of hypoxia or hypoxemia. The training design might be different from institution to institution, but typically might start with the course, which can be online course, and the course can be integrated with exit exam, but that should be followed by workshop, and workshop should be in-person attendance, and you should focus on one modality like lung ultrasound or cranial ultrasound or heart ultrasound, or procedure like pericardiocentesis, pleural tab, or lumbar puncture, for example. So you have to focus on just one modality. In the workshop, you have to practice 20 to 25 studies. About the number, we validated that about 20 studies might be enough to get enough experience on simple modalities like lung ultrasound and heart ultrasound, abdominal ultrasound. You might need even more than that. So if you get 20, 10 of them normal, 10 abnormal, it will be the best. If you're able to teach another 10 to one of your colleagues, if you're able to do another 50 studies as advanced level, you might be ready to be an instructor. Gradual implementation into routine practice, and then integrating point of care ultrasound in the fellowship curriculum, and that would be the future. All of the fellows should be getting education on doing point of care ultrasound in the near future. 20 by 5 rule for 100% success. If you dedicate 20 hours of your life to get a specific scale, you will do it. You will get it. And do that within a short period of time. Do 20 studies, teach another 20 studies, make a checklist for the steps that you need to do, and review it before, review the steps, the checklist, and it might take just 20 seconds before you start in study. Continue to practice minimum 20 minutes per week, and to maintain your experience. That's the minimum that you need to do. We have very helpful AI calculators on our website, the newbeats.academy. They are all free for everyone to access. They might be helpful for you during the training process. We have a PDA calculator integrated in with a nice tissue oxygenation calculator, hypoxemic respiratory failure, cranial ultrasound, lung ultrasound, intestinal ultrasound, respiratory physiology. They are all available, and they are just converting the checklist, what you need to look at, and give you also an idea about the interpretation as artificial intelligence. At the end, I have 3 main conclusions. The crashing infant protocol is a multi-organ assessment by ultrasound in any infant with acute hypoxia or hypoxemia. The crashing infant protocol can unveil unknown lung, heart, abdomen, and the brain pathology. The point of care ultrasound can redirect management in more than 50% of the studies. And I would like to thank everyone in this slide supported our program at the beginning and during the implementation until we have now our center as a center of excellence of applying point of care ultrasound and integrated to our fellowship program. And thank you very much. Happy to get your questions. I have to stop sharing now.
Thank you, Dr. Elsayed. So at this point, we're going to transition over into our Q&A expert panel. We have Dr. Shazia Bhombal, who is an associate professor of pediatrics at Emory University and the vice chair of the National Neonatal POCUS Collaborative. She is a member of the Pan American Hemodynamics Group and the Targeted Neonatal Echocardiography Special Interest Group within the American Society of Echocardiography. We also have Dr. Maki Fraga, who is a professor of pediatrics at the University of Pennsylvania, chair of the National Neonatal POCUS Collaborative, and the chair of the Pediatric and Neonatal Ultrasound Committee for the Society of Critical Care Medicine. We also have Dr. Singh, who is a professor of pediatrics at Loma Linda University, chair of the ASPNIC POCUS Working Group, and chair of the ASPNIC Cardiovascular Hemodynamics Group. Welcome our Q&A panelists. If anybody has any questions, you can go ahead and put that down in the Q&A. We do have a few questions already to start out with. All right, so one of our first questions is regarding implementation of the crashing neonate protocol. So how can we use this protocol for the crashing neonate in the delivery room? Just in thinking about logistics, given the number of people, and also thinking about the utility of handheld machines.
You are muted, Yasser.
Yeah, sorry. So I'll just explain our experience, and I would like to hear also the experience from my colleagues, what they are doing in other centers in the US. So typically the crash infant protocol, if you have someone during resuscitation, we have to apply the NRP, and you have to stick to the NRP steps. And if you have someone who is getting chest compression, we should not stop chest compression to do ultrasound, because that might interrupt the resuscitation. Once the chest compression stopped, but the bagging still needed, and the infant still sick with significant hypoxemia or so, but the heart rate now is picked up. In this situation, you may need to check the lung, heart quickly to assess. You don't have to do the 4 organs. You might be selective according to the situation. So if you're expecting infant with significant with hypoxemia or hypoxia and with poor perfusion, and would like to rule out the typical conditions that we already discussed, you can apply the lung sweep on both sides and the quick assessment of the heart to rule out the significant pathogenic condition that might be contributing to unresponsiveness or poor responsiveness to resuscitation. So the big trick now, if the infant's still getting positive pressure ventilation, you can carry on with that. But if the infant's still getting chest compression, you should not intervene, interrupt the chest compression by doing ultrasound. That's my just a very important clarification. I would like to also to hear from Shazia, Maki, and Yugen.
Hey,
Thank
Yasser,
you,
I can
Yasser.
yeah.
Go ahead.
So, no, that's a great answer and great talk as well. Really enjoyed your talk, Yasser. I agree. I think the real role of the POCUS in the crashing infants and in the crashing infant where the baby is completely collapsed, it can be applied, and we have done it very beautifully in terms where the chest compression is going on, and we can assess the cardiac tamponade and also could do the pericardiocentesis. As you said, really, we should not be interfering with the chest compressions, should not delay and should not stop for the assessment. It should take only a few seconds, and we recommend that we should use subcostal window for the tamponade, contractility, or even what you're assessing the heart perspective, and take only a few seconds, come back, and then review the images. Adults who have got the benefit of the wireless probes, they can use the wireless probes, but we do not have the wireless probes for the babies at the moment. In due course, we should have. At the moment, I will say during the continuous chest compressions, we can use subcostal windows, and mostly with the cardiac leading the collapse and intervene, whether inotropes or fluid or pericardiocentesis. For the lungs, when we listen to the heart, very quick, just the anterior, one each side, just the tension pneumothorax are looking there. So no more than few seconds there. So I think it can be applied as a great role in the delivery unit in due course.
I think we've also used it in the DR, and we've known, for example, for hydropic patients. And when someone had mentioned about what kind of machine to utilize, oftentimes with our DR, we have simulations, or we have areas where we know everyone's going to be. So we've used both full-size machines and smaller machines, and just knowing where those machines are for easy access, and knowing where the person's going to be to use it, so that you don't interrupt care. But for cases where it may be beneficial having available in there if you're just starting off, with those who have experience, because if you're not having experience or doing that, it can take away a little bit of time from resuscitation.
Yeah, I
agree, and
was
that
just
should
going
be
to
done
add-
by, yeah, Mackie, please go ahead.
Yeah, no, I was just going to add that, so here at CHOP, we have not formally introduced this protocol in the delivery room, but we use point-of-care ultrasound for any emergent procedure, and the best example is the hydropic baby that needs chest tubes right away after birth. We do use in that case. Yeah, Yogan, go ahead.
Just the one point what Shaji was saying, I agree. In these situations, especially with the crashing infant, when the coding is going on, it should be done by the most experienced person. That's not the time for teach and train. Minimum time, maximum efficacy, and interpretation can be done just on the side, on the screen as well. So so this one should be done by the most experienced person available in the situation.
But yeah, I mean, during the admission on baby here in the unit, well, first of all, Yasser, I want to thank you for not only for the talk, but for all you actually do in point-of-care ultrasound. It's unbelievable the amount of things you do and the many resources you have made available for everyone. So thank you for that. Yeah, so going back to how we use this, I think, what you presented, Yasser, is great, but there are many different, I would say, clinical situations that I personally could differentiate. The crashing infant could be the baby who is stable. Sorry, I'm going to mute you because there is a lot of echo. The baby who is stable and unexpectedly crashes, right? Like he's rapidly decompensating and we don't know why. So yes, then we can run with the ultrasound and check things that we think could be happening. Going ABC, following the NRP, right? Ruling out attention pneumothorax, ruling out pericardial tamponade. So that's extremely helpful, and we actually use point-of-care ultrasound in our NICU in that way. Now, if we have an infant who is critically ill and is presented with abdominal distension, like a more progressive clinical picture. So then here at CHOP, for example, we have not introduced bowel ultrasound just because, it all depends what your needs are at your institution and where you practice, right? So here we have availability of radiologists who actually come to the NICU anytime and do that for us right away. So, but it's a different clinical scenario. Same thing, and dealing the unknown. But like I see the how useful this is in the very, very critical situations where you have to act right now.
Yeah, I think that's very important to also highlight that the direction that might be different according to the case scenario. For example, if you have infant with abdominal distension with gut injury, I don't have to maybe assess the lung and the heart at that time. I have to start and focus on the abdomen, relying on different team like radiologist. That might be considered until you have, which I still prefer, I still recommend to have a team among the neonatologists in NICU to do the ultrasound. Having someone from outside that might be typically integrated technique to the clinical, because sometimes they are very busy. They don't know if the infant is really dying, very sick, or stable. Sometimes you see a lot of artifacts. You may misinterpret the artifacts as maybe question mark hematosis, and we have seen that in other centers relying on the technicians or the radiologists doing the ultrasound. But if I see something which is not really matching the clinical scenario, I have to review it again. So I can see hematosis that, like the infant that does not behave like neck, or I can see abnormal pathology which is consistent with the volvulus, not really neck. So I have to inform the radiologist, sorry, the pediatric surgery right away. So having the person doing the technique like is the same person, the clinician who integrate with the biochemical marker, the clinical assessment, that's typically more beneficial and might limit the misinterpretation from having someone from outside. If you don't have the expert yet, that's understandable, but I think it made a big difference in our center after we shifted from relying on only radiologists and X-ray by having our own team doing the ultrasound, and we had a lot of misinterpretation, misdiagnosed cases, either overdiagnosis or underdiagnosis of gut injury.
A couple of more questions in our Q&A, specifically relating to bowel POCUS. What settings on color scale do you use when looking at bowel perfusion?
Yeah, that's very important question. So as I mentioned, we do it in 2D and color Doppler. So in 2D, for the liver we assess, I have to highlight that we are using the microconvex probe for the liver assessment, not the linear, microconvex high frequency probe. And you have to do it in 2D and color Doppler, two perpendicular planes for the right lobe and left lobe, and then change the probe to the linear probe or hockey stick probe and assess longitudinal and the transverse. Longitudinal and transverse, 4 quadrants and midgut, and 2D. And in 2D, you have to have the most superficial setting. So because you have the bowel very superficial, so you have to maybe a special preset for the gut, or if you don't have it, you can have also the vascular preset, which is also helpful to see the gut very well by 2D. And then apply a color Doppler 2x2 box with the single digit scale. Scale should be very low, otherwise you'll see a lot of artifacts. And if you have a lot of air of the infant on high frequency jet ventilation, you will get a lot of artifacts and shaking of the color. So that might affect the clarity of the color. You need to adjust the gain. If you see too much gain, that's probably because you have too much air interface or artifacts. You need to adjust the gain until you see very small circumscribed speckles of color, not very diffuse among the entire image. If you see 3 to 9 speckles in 2x2 box, that's normal perfusion. If you see circles, zebra, or Y-shaped, is hyperemia. Or if you cannot see color at all, even when you go even down on the scale, it means that you have severe ischemia. Again, you have to do a lot of normal cases to get into that level to detect abnormal perfusion. And that should be under mentorship. You should get this experience with under supervision, because the decision might be very critical. We are talking about keep the infant NPO, start antibiotics, consider central line, or maybe consult pediatric surgery. So the decision is really critical. So you should get the experience and be signed off by someone expert.
Another question regarding teaching. How many hours of learning is realistically needed for a novice to be able to do the crashing infant protocol, as it involves some degree of proficiency in doing ultrasound?
I may not consider number of hours. I may consider the competency. That might be variable, because we have someone might get the experience in ultrasound very quickly. Someone else might take more longer time to get the experience. It is based on doing certain number of cases in the good quality. So we consider 20 or close to 20 good quality. You may need to do 50 cases to reach that 20 cases of good quality. You may need to do like 10 extra to reach that 20. That may be variable. So you need to get very good quality, and the good quality is the reference is the expert. Is Maki, Eugen, or Shazia is the expert person to decide your quality now is good. That's my reference. Now I will sign you off. And now you can provide lung ultrasound or cranial ultrasound or cardiac POCUS independently. You don't have to ask me every time you do the study, even if I'm not around, unless you have a question. So that will be reached that level. It will be signed off that you did a very good quality, a reasonable number of cases. That might be different in CHOP from our unit, we are considering 20 cases as a reasonable number. And I may need to add extra if I see the person is not really competent enough. So the competency is the definition, which is why should be defined by someone expert. Now you are competent. I feel they are competent. You did a good quality of studies. Not all of them normal, at least 50% abnormal cases. I would like also to hear from our colleagues.
Yes, sir, I agree with you. I think it should be competency-based. Having said that, there should be minimum number of scans as well. I think there should be definitely a course followed by a X number of studies for a particular organ with the logbooks, which should be reviewed by the mentor locally. And there should be some scanning under direct supervision as well. We can look on the safety mechanism, how long person takes, on the hand-eye coordination skills. And then once we are happy, these three processes, the person can be signed off in that particular organ. In terms of the question was about the number of hours for the casting infant protocol. I think as you can see, and Yasser talked about the different organs. So person performing the research protocol need to have the competency in the different organs. So once person is confident in the other organs, it doesn't take long. But really key is to get the competency in the heart, lungs, which is the more crucial in the crashing infant. And then obviously comes the other, which are more decompensating infants, where the abdomen and the brain will come as well.
I think one other thing that I just wanted to add, can you hear me okay? Is Yasser is such a great team where he is, who's able to sign things off. And maybe in institutions where you're starting POCUS, that you may need to look for other colleagues or other divisions or departments to help you as you try to sign off. So going to courses and certainly starting off with that, doing Yasser's online and being in person is great. When you come back to an institution, finding some mentorship, and that may include reaching out to cardiology or radiology or PICU or ED who have the expertise, and really consider that and look for your resources. Because the competency is going to be a huge thing, and trying to figure out that among individual institutions and programs will be more institutional dependent, at least at this time.
I think we have time for one more question. And we have a question about if the POCUS findings are confirmed with standard radiologic studies prior to surgery.
So you're talking about the abdominal ultrasound, right? I assume abdominal ultrasound, and you're talking about, yeah, so the surgical cases. So I have to mention that to get into that level of using abdominal ultrasound to help pediatric surgery, you need more than 1 year. I'm talking about maybe 2 or 3 years to get the competence. You need to see significant number of cases of beyond the neck. I'm talking about volvulus, malrotation, and other pathologies, and they are not so many. So you may need to wait 1 year to get maybe 2 or 3 cases of volvulus. So that's why it's taking a long time. So to build that experience, you need to apply the ultrasound, and you need to know what are the red flags. So I mentioned the red flags in the ultrasound about like they are related to the 2D or the color Doppler, and these red flags should be integrated into the clinical assessment. The infant with volvulus should be really sick with lactic acidosis, with some exceptions. Some surgical cases might be not an emergency situation like stricture or adhesions of the bowel that might be kind of elective, but can be also diagnosed by ultrasound. So we have to specify the surgical emergencies and non-emergencies. In emergencies, it is very critical. You need to get a lot of experience with the red flags, and these red flags we will highlight to the pediatric surgeon. You explain that to the team, and also get a consensus among the team that the red flags are consistent with the clinical condition and the surgeon is happy to go ahead. That will take a long time again. That's very important to consider. To build your experience, I advocate to do the same as I did. If don't make any suggestion based on the ultrasound for at least 1 to 2 years. Do the ultrasound and then get the details go with the surgeon to the OR and see the pathology and compare that with the ultrasound and build your experience. This is the way that I got the confidence myself, and I get the trust from the pediatric surgeon in what we are doing. Because one case, just you need one case that was went for surgery and was not indicated, that might kill the technique for you and for the entire institution. So you have to be very careful in this indication. You need very long time. You need a good mentorship. You need to pay a lot of time looking at the pathology yourself. Go to the OR and look at the pathology compared to ultrasound before making any decisions. So it is very tricky. Abdominal ultrasound is a separate. It is by itself. It is a special experience. You need a lot of time to get the experience. Lung ultrasound is easy. Everyone should do lung ultrasound, including our colleagues from RT.
Wonderful. Thank you so much to our speaker, Dr. Elsayed, and to our panelists, Dr. Bhombal, Dr. Fraga, and Dr. Singh. Please join us for our next webinar. It will be on January 23rd in the new year. If you want to stay up to date and get invitations for our upcoming events, there's a QR code on your screen where you can join our list so that we can send you email invitations. Otherwise, you can also check out our webpage at neopocuscollab.com and join that way as well. Some additional POCUS resources that we have out there for you. QR codes are on this screen. Hope you guys enjoyed this inaugural episode of our webinar series, and we hope to see you in the next one.
Thank you, everyone. Thanks, Yasser.
Thank you.
Awesome
Thank
work.
you, everyone.
Bye.
Thank you, Karina. Bye. Thanks, everyone.